So it's is it here? Here. It's a pleasure to be here. I can see you if I hold my hands up, my lights. So I'm going to give you a short course in the causes of vascular Ehlers-Danlos syndrome and some of the consequences of what those mutations are. As Francisca said, I'm a medical geneticist at the University of Washington, direct a diagnostic lab there, and so have a lot of experience on both sides of it. And one of the most lovely times I spent recently was from February of 2020 through July of 2020 in Ghent, in Francisca's group in Belgium. So we sometimes get the feeling that we can walk in the door and make diagnoses. This is an image from the EDS Society with Kathy Bowen, who was really instrumental in getting this all going. And these are the images of people with vascular EDS. Now, there are a couple of exceptions. Hal Dietz is down there in the left lower corner, and I'm somewhere else in the picture. We don't have EDS. And the one in the center on the bottom was her son, David, who got things going. So in the history of this and understanding and where it came from, in the 1930s, Sack, who was a German pathologist, recognized what he called status dysvascularis. In the 1960s, Barabbas, who was a British surgeon, identified people who had a form of Ehlers-Danlos syndrome, but it was unusual in the sense that they had many, many more vascular complications. Peter Beighton put that into his book in 1969 and in his collection of people with Ehlers-Danlos syndrome, and it became the fourth type that was identified. And then in the 1980s, mutations were identified in the type 3 collagen gene, and then the reclassification gave it the descriptive name of vascular Ehlers-Danlos syndrome. And I always worried that that would minimize the recognition of the other kinds of complications. It doesn't seem to have. So this is a story with Darren, who I saw early on in my career in Seattle. He was born with a club foot. He had a bowel rupture at 6. He had a tibial bleed at 12. He had problems with his eyes. Had a stroke at 28, a brachial artery tear while he was bowling when he was 32. And when he was 35, he had a colonic rupture, and that led to his death from sepsis. This is his family history. Darren is the one in the middle with the square. His mother died of uterine rupture during delivery of his younger sister. Darren had 2 daughters, one whom was affected, one who's not, and the one that was affected has subsequently died. But we were able to do prenatal testing in her pregnancy, and she had a normal boy. That's a very different family history than what we see here, where the family came to attention because of the 30-year-old there was seen when she was about 18 because she had continuing headaches. She had a diminished vertebral artery. And she was found, instead of having something that made an abnormal protein, she made half the normal amount of the protein. And if you look, her dad had the same mutation. He was doing well at 55. Her grandfather had had a couple of things, including knee replacements at 70, and was doing well at 80. So a very different trajectory of the condition and what was going on. Our discovery when we find genetic conditions is almost always to find the most severely affected. And so discovery on this graph goes from right to left, and we find the milder ones later on as we are accessing and sequencing more people. So the way we make a diagnosis is really, it starts almost always with a clinical exam. Now we're beginning to see people who've had whole exomes done, and it's found as a secondary finding, a sort of unexpected finding. They're not done because this is what they're looking for. So we look at the skin, we look at hands. You can see the picture of the hands here with the vessels. You saw dramatic pictures of hands from Christy early on in the this morning. You ask the questions, do the fingers look tapered, or is there wrinkling on the palms of the hands? Is there a typical face? And the answer is there is a typical face, but it's uncommon. So, and for many people, including me, walking in the door does not always give you the diagnosis. Does the skin seem thin? Are the joints normal? Are there murmurs or bruits? Are there things that we can hear? And all of those contribute to what's going on. And when I was in medical school, when Claire was in medical school, when the older generation of physicians were, that the key to diagnosis is complete history of the present illness and a comprehensive physical examination. And the most important part is history. We are beyond that at this point. Do cardiologists still use stethoscopes? Not often. They do echocardiography, MRI, MRA, and so now we've really moved to the point where the diagnosis is made by doing genetic studies. And genetic studies are no more expensive than the typical other kinds of investigations. Getting there is sometimes a little more difficult. So one kind of mutation gives you half the normal amount of type 3 collagen, which is the protein that's in the arterial wall, it's in the bowel wall, it's in the uterus, it's in skin, it's everywhere. But it particularly has effects in those tissues that we've already learned about. And if you make half, what's made is normal structure, but there's less of it, and it's a little bit more problematic. Now, the collagen molecule is unusual, and this is a picture of it. It's a trimer, so there are 3 chains that are wound around each other. And if you sort of take a straw's eyes view and look right down the middle of it, you can see on the bottom left, this has does it have an arrow? There it is. I have to point up here, right? So over there, you can see that green residue is glycine, and glycine is in every 3rd position in the chain. And anything that disrupts the glycine makes it so that that chain doesn't fit together when it folds. So the consequence of that is you have 2 copies of the gene. One is altered, but you assemble them in trimers, and so you can make those that have only normal molecules, these guys down at the bottom. You can make them that have all abnormal molecules, or you can make 6 other different combinations that have either 1 or 2 abnormal chains. So 7/8 of all the molecules that you make under these circumstances are abnormal. So these are quite different in terms of what they do. This is just a depiction of the variation in how many different alterations. So this represents the helical part of the collagen molecule, and these are substitutions of glycine by serine or cysteine or arginine or tryptophan or alanine or valine or aspartic acid or glutamic acid. You can see that the more frequent ones are in the large amino acids here, and the smaller ones have fewer, and they have milder phenotypes. And so they are less likely to come to attention, not because they're less frequent. So there's a very interesting thing about this, and about 50% of people who have vascular EDS are the first person in their family to have it. So that makes it difficult to recognize. We don't have the clues from family, which are very, very helpful in making a diagnosis. And when a child is born into a family that has either a father or a mother who has vascular EDS, the chance of having vascular EDS is 50%, because there's 1 copy of the gene that's altered, 1 that's not, and you only pass on 1 copy as you go. So that's unusual. We have seen families where they start and they have 1 affected child, and then we ask, what's the risk of having a second child? And so we were able to look at families where we had parental DNA and everything. And there was a significant number of people in the family, a parent, who was mosaic for a mutation. That means that some cells were affected, but other cells were not. And those cells, I'll show you in a minute, could be passed on. And then other families where there were already 2 affected people, but the parents were unaffected. And so one of those parents was also mosaic. So we now recommend that every person who's identified who is new in a family has parents studied, so that we can know what the recurrence risk is. Now, obviously, if we discover them at 30 and their parents are 60, and they've had other siblings, then they know they just represent a new mutation in themselves, and it's not parental. So here you can see the effect is that if there's a mutation that occurs after fertilization in the parent, that you have some cells. So some will make regular tissues, blood vessels, other things like that, but others go into the germline and can be transmitted either to the testes or to the ovary. The mosaic individuals with this are almost never clinically affected. There's rare examples where they are. So, and it depends on how many cells go into the germline. And you can see over here, if 4 are segregated to the germline from the body and only one of them is affected, the recurrence risk is 12.5%. If it's only one that goes, then it's a 50% recurrence because each of those cells has 2 copies, one of which is altered. So mosaicism is a not infrequent cause of recurrence in families, and we have to look at those. That's not that that's a geneticist talking, and it's important to do. It doesn't get into the community very actively. So what we identified, and this is looking here at about for this at about 1,300 people with vascular EDS, and we were interested in what happens to them and what's going on. And what you can see is that this is the survival curve in the US population here, and the median survival is in the 70s. It's a little bit longer for women than for men. This is the survival for people with vascular EDS. These overestimate the decrease in longevity because we do not find people who are mild. And so these data, which say there's a median survival of 50, really don't represent the true figure that's there, but it's the best we can do because this is what we have. What we see with this, and Kathy Bowen was instrumental in telling us, is that the mortality very on is predominantly male compared to female. And Kathy said, "You're missing our teenage boys," and she was right. And it wasn't until we got a larger population that we could see that. So there's a difference between those people who are making normal molecules but less of them, and you can see here that the survival story is quite different. These are the people who are making normal things, and so this is every time this goes down represents a death in the population. And so you can see that these have a very different survival curve, and that's maintained. And we are seeing them more and more. We thought they were very rare, but it's actually becoming a significant portion of people that we're seeing. One of the reasons that we do sequencing is because we can stratify the risks. So the sequencing here, so this is the people who have half the abnormal amount. These are all the people who have substitutions, but if we look at what amino acid substitutes, or if we get splicing abnormalities there. So here, what amino acid substitutes. So serines are milder. They're a small amino acid. Arginines, aspartic acid, and valine, which are bigger ones, are down here. And then we have these other disruption things which alter splicing. So another thing is, what about pregnancy? When we first started doing these kinds of things, if they knew about the diagnosis, the attitude was, don't get pregnant because you will die. Okay? Very clear. If you do get pregnant, terminate the pregnancy or you will die. If you don't terminate the pregnancy, go see somebody else because I'm not going to take care of you. So a small number of women who are pregnant with vascular EDS do die. The rate is somewhere around 4 to 5 people per 100. That's a lot higher than in the standard population. But that is not, don't get pregnant because you will die. 50% or more of women who have vascular EDS, deliver vaginally, have no complications, do not have cervical tears, do not have uterine tears, and survive pregnancies and may have many pregnancies. That's almost certainly dependent on what the mutations are, but that hasn't really been figured out. So, and what we did was to look at the survival of women who had been pregnant as opposed to women who had not been pregnant, and you can see that the curves are basically the same. So that tells us something that, getting pregnant is not a death sentence. So we get to this point and we say, well, what do we do about care? And I think everyone, Katie was very articulate about it in the sense of having a care team. And that there has to be somebody who's the primary care physician here. So the patient is the yellow ball, and the specialists here have to be involved. And the interaction and the coordination among them is vital, so they have to be able to talk to each other. And so in many centers now, we're seeing this happen. And this is important, not only for vascular EDS, it's true for all rare conditions where the knowledge in the community is not high. One of the things that we hear often is, my doctor doesn't know anything about this condition. And the answer is, your doctor doesn't know anything about this condition by this name. But look at the complications that are occurring. Dissections, bowel rupture. Dissections occur in other things. Bowel rupture occurs with diverticulitis. So many of the things that happen to people that are seen in the general population. They're just seen in different contexts. And the difference here is that we see a couple of those things happen. So in people who do not have a family history, the way to diagnosis is actually what else is happening? Has something else happened? Is there another event? So if somebody had spontaneous pneumothorax as well as having a bowel rupture, or spontaneous pneumothorax as well as having an arterial dissection, or an arterial dissection and a bowel rupture, that's a red flag, and those people need to be tested right away. So the other aspect, this is one aspect of treatment. The other aspect is, are drug therapies helpful? And the answer is, for a long time, celiprolol has been the darling of the French and the others. The data supporting its, having a dramatic effect is not great. And then Hal Dietz at Hopkins and the group in France have also developed mouse models to look. And there is a series of medications that look like they can make a difference in survival, going from curves like this to going out here, and sometimes even going out here, depending on the nature of the drug and what's going on. And so some drugs are now being tested, combinations of drugs are being tested. And I think the answer from that is that we certainly have indications of potentially therapeutic drugs that may enhance survival, and we hope complication-free lifestyles. We have to be cautious about it because people still are not mice. And there's a whole book written about mice and men for those of you who want to read about and understand the differences. But it still is important to understand. So I think we are at that point now, the inflection point. We're getting to a point where we may have something coming down the road very soon. So thank you. Thank you.